Hello, John.
Hey, how you doing, Sarath?
Hi. How are you?
Good. Just setting up.
Yeah. I'm fine. I'm good, and I'm ready.
Yeah, okay, about 5 minutes, okay?
Yeah, sure.
Yeah, let me turn off the, I've got,
John, excuse me. Can you hear me?
what's that?
Can you make Dr. Suresh as a panelist because he's our
Okay. Oh, yeah, the Dr. Dugan.
yes.
He's been here before, right?
Yeah.
How are things going in Sri Lanka?
Not so bad.
Good.
Not so bad.
Back to normal, right?
I mean, I can't say normal. Yeah.
Well, back to pre-COVID.
Yeah. Can say near normal. Hello.
It's the
Let's say
same.
hi to Dr. Dugani. Hi, Dr. Suresh.
Hi, Dr. Dugani?
I think you are muted.
Yeah, can you hear me?
Yeah.
Yes.
Now we can hear you.
Yes.
Yes.
Nice to see you again, friends.
Yeah, nice
Okay.
to see you as well.
Yes.
Now, do you have any videos or anything you want to check?
Yeah. Videos are there. Videos are there.
Go ahead and
Can I try them?
go ahead.
Can you see the screen?
Yes.
Okay.
You want to make it full size presentation mode
Yeah, that's right.
at the bottom to the right.
Play. Okay.
There you go. Perfect. Now, do you have any videos?
Yes.
Do you have any sound in the videos?
No.
Okay. Okay. So there's no problem. Let's see if the video runs. Go ahead. Try the
Yeah.
video to run.
Yes, I'll play the video.
Yeah.
Is it okay?
Yes. Okay, you ready to start, Suresh?
Yeah. All right.
Yeah,
Yeah,
looks good.
you ready to start, Doc?
Oh, yeah, sure.
Yeah, people will come in as we go along. Okay, so I'm gonna get you up the screen, so
Yes.
we can introduce you, okay?
Okay.
I
Okay.
need to get you off the screen sharing.
Yes.
Okay, you ready, Sarath?
Yeah, I'm ready.
Right.
Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. Here we are in Miami Beach in the background. We have the honor today of broadcasting the semi-regular Sri Lanka Neurosurgery Grand Rounds hosted by Sarath Munasinghe, a lover of this technology for education and networking. Welcome, Sarath. It's all yours.
Thank you, John. Thank you very much. And welcome to another episode of Neurosurgical Grand Rounds from Sri Lanka. So good morning, good evening, good afternoon, wherever you are. So today also we have the honor of another eminent and popular neurosurgeon from India, from Hubali, Dr. Suresh Dugani, who joined with us last time as well in the discussion of olfactory groove meningioma. So today we are going to discuss about another important topic, which is on falcine and parasagittal meningioma. So today, Dr. Suresh will be doing the most of the discussion, and will do the discussion with the videos and explain you the nuances, the technical nuances, and the complications and how to avoid them. So welcome to Sri Lanka Neurosurgery Grand Rounds, Dr. Suresh. It's a great honor to have you on board today as well. So today it's all yours. So you can go ahead and start the proceedings. Thank you very much for getting back again.
Thank you, Surat. And Dr. John. It's indeed a pleasure and honor to be with you again and share and learn from each other. Thank you very much. And as we had planned earlier, today this meeting will discuss with the management of parasagittal falcine meningiomas. Without taking much of a time, shall we go ahead with the screen sharing?
Sure.
Yes. Right. Is it okay? Surat, can you?
Yes.
Yeah, thank you. Yes. So
I'm sorry. Okay, go ahead. Go ahead.
Okay. I'll put off the video. It's okay?
Yep, okay.
Okay. Right. So today we'll go ahead and discuss on the management of parafalcine meningiomas, Fox meningiomas, or parasagittal meningiomas. I bring greetings from India, South India, Hubli, Dharwad, Karnataka state. Definition-wise, Fox or falcine meningiomas, as defined by Professor Harvey Cushing, is a meningioma arising from the Fox cerebri and completely concealed by oral cortex, not involving the superior sagittal sinus. In you may have three types of lesions. One originating from the convexity, touching the fox, touching the midline. Origin may be in the convexity. Second, real fox meningioma originate from midline. Fox grows laterally and superiorly. Third variety, we call it as parasagittal, where it tends to originate from the inferior and lateral wall of superior sagittal sinus, grows down into the brain matter cortex and a midline and the vertex. For all practical purposes of management, the axis, the approach, and the management remains the same when we are dealing with these three types of meningiomas in the midline, parasagittal, falcine regions. They form about 9% of all meningiomas. There is a female preponderance, 1:4. The age is between 50 to 65 years of life presentation. Most important, before we proceed with the understanding of these meningiomas, anatomy related to these meningiomas is at most importance, because these are very formidable lesions involving the good amount of brain and important vital structures, neurovascular structures like fox cerebri, superior sagittal sinus, inferior sagittal sinus, surface cortical veins, frontal, parietal, and occipital cortex, anterior cerebral arteries, and corpus callosum are the close relations. These lesions, as we just now saw, originate from the fox cerebri, starting from all along the length to the posterior, up to the straight sinus. Anywhere in this location, they may originate frontal, parietal, and occipital. And it is very intimately related to the frontal lobe in the front, parietal lobe, and occipital lobe behind, and the paramedian structures. Arterial and venous relations are of utmost importance when we plan to treat these lesions because of the important neurovascular structures. The anterior part of the fox cerebri is supplied by anterior division of middle meningeal artery, anterior ethmoidal artery, and pericallosal artery from anterior cerebral artery. The mid and posterior part of the fox cerebri is supplied by posterior division of the middle meningeal artery, meningohypophyseal trunk of the internal carotid artery, posterior cerebral artery, pericallosal artery, and posterior meningeal arteries of the vertebro-bacillary system. This understanding is at most importance when we proceed with the management of these lesions. These tumors, when they're in the paramedian location, they're very intimately connected. Most common vessel, that is the anterior cerebral artery and the anterior communicating artery, and distal with the posterior cerebral artery and the perforating branches of middle cerebral artery. Most important relation of these tumors is superior sagittal sinus and inferior sagittal sinus. They form parts in these tumors, and we need them and treat accordingly. These are the venous relations of the tumors in the midline, that front to back. Next important relation forms the cortical veins on the surface of the brain. From front to back, important cortical surface draining veins in the frontal region, in the parietal region, and in the occipital region. These veins are very important when it comes to the management of these lesions, which can make or break the surgical management of these tumors. Next important relation of these tumors, when it grows down to the corpus callosum in the midline and get affected, it may get compressed or shifted or infiltrated due to the tumor. One must keep this in mind when we are managing these lesions. The classification of these meningiomas goes, it is anterior types of anterior located, between the anterior cranial fossa to coronal suture, middle type from coronal suture to lambdoid, and posterior type extend from the lambdoid suture to the torcula anatomically to understand these lesions, but always there is a permutations and combinations and overlapping of the boundaries of these tumors one must understand. Over the last 30 years, we have treated nearly about 240 cases of midline meningiomas, and 134 were anterior forks, 64 were midline mid-forks, and 39 were posterior forks, and we had 34 recurrences and were treated accordingly. On that basis, we have formulated these lesions depending on their origin. Type 1 originate from the center of the fork, as shown here in the diagram and in the scan. Type 2 originates from the inferior edge of the forks, cerebri, grows downwards inferiorly into the corpus callosum and limbic system and cingulate gyrus. Type 3 originates from the forks superior margin of the forks, superior sagittal sinus junction, as shown here, and involves the superior sagittal sinus in few cases. Fourth type originates from the forks, grows superiorly, erodes the skull and erodes the scalp, superior sagittal sinus, and may go outwards. These lesions present with various manifestations depending on the location of the tumor, anterior, mid, and frontal regions, and the clinical manifestations vary. Commonly, they present with headache, focal seizures, focal motor seizures, sensory seizures becoming generalized. When they're in the frontal and parietal region, they may present with abnormal behavior, go to a psychiatrist first, then they come back to us. Weakness of the lower limbs, one half of the body, weakness of both the lower limbs or one lower limb or one half of the body, that's hemiparesis is a possibility. Incontinence of urine when the lesion is in the frontal midline, and impaired vision due to the raised ICT may cause papilledema and secondary optic atrophy. They may have signs in the form of hemiparesis, paraparesis, lower limb monoparesis. Patient may be dull, withdrawn, social with the loss of social disinhibition, incontinence of urine, and hemianopias. And these manifestations can be in permutations and combinations, as I mentioned to you earlier, depending on the locations of the lesions. To diagnose these lesions, we need CT scan, plane and contrast, with the bone windows and the 3D reconstructions, MRI scan brain, plane and contrast, MR angiography, MR venography, MRI DTI images, MR functional MRI, and navigation assistance are most important diagnostic tools in investigating these tumors. MRI venogram is invaluable in treating these lesions because surgery involves direct cortical veins in relation to the tumor. Location and understanding of these cortical veins in relation to the tumor, approach and access to the tumor, obliteration of the superior sagittal sinus or inferior sagittal sinus, safe area of approach can be planned depending on the MRI. Again, DTI images are of utmost importance because these lesions involve midline, frontal region, and parietal region, involve the corticospinal tracts. Either they may displace laterally, they may elevate them, or they may displace anteriorly, they may displace posteriorly. This is very important to understand the DTI images, which gives us an important information when tackling these lesions and approach to these lesions, prevent the injury to tracts and sensory cortex, and coming out with a good outcome in these lesions. Navigation assistance is invaluable in this because, as I mentioned to you earlier, the location of the lesions is so critical. It will be on the motor area or in the parietal area, in the frontal area. The locating the anterior border, posterior border, deeper border, and superior border, medial border is of utmost importance to plan the craniotomy in this case, in these lesions, because of the important brain relations in relation to this. These are the few planned navigation guided craniotomies. Once you do the craniotomy, next important point comes the location of the tumor on the surface, anterior border, medial border, and the lateral border, and the posterior border, so that you have a virtual understanding of the tumor on the surface of the brain when you start treating these lesions. To treat these lesions better, we need a cool surgeon, very important, because these take a long time and in the important neurovascular area. High-end operating microscope, cutting loops when the tumor is very firm, it may not come into ultrasonic aspirate. Soft tissue debrider, again, when the tumors are firm in these locations, we need that. Ultrasonic surgical aspirate, neuroendoscopes to see inside the tumor bed to have the complete excision. High-speed micromotor drills to do a good craniotomy. Osteotomes, intraoperative electrophysiological monitoring is of utmost importance. Intraoperative tumor fluorescence is again important to see the remnant lesion and the surrounding lesion. Neuronavigation and microplates to have skull reconstruction with these large tumors. Craniotomy, as I mentioned to you earlier, we prefer to do a curvilinear flap depending on the location of the lesion. We do them in the front. Always we advise or we prefer to take supraorbital, supratrochlear, and superficial temporal branch feeding the flap in the anterior 1/3 of the lesions. Similarly, in the posterior 1/3, earlier days they used to do suprasagittal flap, which used to cut off the blood from the trochlear and supraorbital and superficial temporal and auricular. Now we stop that. We make a curvilinear flap, a big flap on the scalp, which has a blood supply from the supraorbital, supratrochlear, and superficial temporal and posterior auricular, and opposite side vascularity is well maintained. This help us to postoperatively the wound healing better, and the vascularity is well maintained. We do curvilinear occipital flap on the superficial temporal artery and the branches of the posterior meningeal vessels and scalp vessels. This is 37 years old male presented with headache, seizure, and post-ictal weakness on the right side limbs of 6 months duration. This is the MRI showing you the mid-fox meningioma with irregular surface, significant edema, pressure effect on the frontal and parietal lobes, going down the fox with surrounding edema, and a big cystic component when it goes deeper parts of the frontal and parietal lobe. We did a navigation guided planning of the craniotomy. The tumor is marked on the surface, anterior border, lateral border, medial border, and posterior border. Depending on that, the craniotomy is planned. We, as I mentioned to you earlier, we make a curvilinear flap and take the flap down on superficial temporal artery, supraorbital and supratrochlear arteries, so that flap necrosis in large flaps is prevented. Dura is opened with the base towards the midline, as shown here. The dural opening needs to be quite wide. Always on the navigation guidance or visual planning of the surgery, we prefer to do a large craniotomies in these cases rather than small ones, and struggle during the surgery if the border of the tumor goes beyond the craniotomy. Now, during the reflection of the diameter, one needs to be very careful, because the cortical surface veins and the tumor surface, they may be densely adherent to the dura mater. At that juncture, we need to separate the dura mater very gently and preventing the cortical surface veins. Once we reflect the dura mater, we reach the midline is most important, and the dura is reflected backwards. Now tumor is on the surface coming up here. There's no issue in the parietal and frontal lobes. Tumor capsule is opened in a cruciate manner, and once we do that, the biopsy is taken and we start the debulking and decompressing the lesion. Remember, in these cases, the more you debulk and reduce the tumor size, more comfortable you are in the subsequent stages of your surgery to dissect these lesions. So now this tumor appears to be firm and it is not coming easily in bipolar dissection and suction dissection. It is not coming easily into the ultrasonic aspirate. So we need to use debrider and cut the tumor and rapidly decompress. Once we do that, slowly the capsule starts separating. We must remember the arachnoidal boundary between the tumor and the surrounding brain always available there. We need to identify it and go behind it. Now that's a cortical vein which has been displaced anteriorly and shifted anteriorly, and tumor is elevated. At this juncture, we must always preserve the cortical vein under any circumstances with a sharp dissection under high illumination and high magnification. Keep separating the arachnoid and the tumor starts separating. Now you see the tumor surface is nodular and firm. As you keep separating, the tumor starts separating from the surrounding normal brain. And I want you to see our coagulation is on the tumor surface only and not on the brain surface. Now, we dissected and brought into the operating field, we further go ahead and debulk the tumor with the soft tissue divider shown here. It's a very important and vital tool for the rapid, fast, and safe decompression or debulking the tumor in such a firm lesion fail to come with the ultrasonic aspirate. The lateral part, the anterior part of the tumor is being debulked. I want you to see the vascularity of the tumor as you debulk. So the process will be debulk, sorry. The procedure will be debulk and dissect. Debulk and dissect. That is the procedure which needs to be followed. And tumor capsule, keep dissecting and separating from the surrounding normal brain and keep protecting the normal cortical surface and the cortical veins. Now we're going anteriorly, and as we debulk, we keep pulling the tumor capsule into the operating field. And again, remember, we should operate these lesions under high illumination and magnification. Now we are taken off the anterior part, the lateral part, and the deeper part. Now the medial part, which is originating from the fox, needs to be addressed. Very important now at this stage. Start dissecting from the midline and go deeper, superficial to deeper, and keep separating the tumor from the midline fox and superior sagittal sinus junction. Utmost importance. Now we are debulking the tumor from the superior surface and paramedian from the fox. This is a fox in the midline. This is the posterior part of the tumor, or the tumor is within the cranium. As you keep debulking the tumor, you start getting good amount of space between the surrounding normal brain and the tumor surface. Again, as you go medially, the tumor becomes more and more vascular and the adherence becomes more firmer, and we need to spend more time during the dissection of these lesions. Now the tumor from the fox is being separated, coagulated, and dissected. Here we may have more of a vascularity coming from the fox region. Now we are in the anterior part of the tumor. Once that is dissected from the fox, now again you debulk the tumor from the anterior region and the fox. All the cortical veins are protected and shifted anteriorly. That is extremely important to keep them covered by the wet cottons, because due to inadvertent movements, we should not damage these vessels and cause problem. Now we are debulking the anterior and medial part of the tumor, which is separated from the posterior frontal region, and we are going medially all the time inside tumor mass and keep on debulking and dissecting. And every stage of our surgery, we must achieve hemostasis before going further. At no time there should be blood during the dissection. Dissect, debulk, and achieve the hemostasis. Again, continue the debulk and achieve the hemostasis. Keep the area clean so that the anatomical surrounding structures are well preserved and you are very comfortable and safely you are excising the lesion. Now we are going posteriorly and the whole lesion appears to be maximally debulked. Now with the hook or with the angled dissection. Now how easily, once you have done that, the tumor starts separating from the surrounding structures. Another important thing I would like to mention by using the soft tissue debrider is that it sucks the tumor and cuts it. So when it sucks the tumor, it helps us naturally to separate the tumor from the surrounding brain, and it helps us, the tumor starts getting easily separated from the surrounding brain. That's another added advantage of using a soft tissue debrider. It sucks and pulls the tumor into the field. Now you can see the medial, the lateral, and the posterior part of the tumor is being separated, and the tumor surface is coagulated and the bleeding is reduced. And the normal brain is protected by cortex. We are on the motor area. Motor area, we have the corticospinal tract. And under no circumstances, any part of, even though this is a gliotic brain, we should not damage or touch the brain under any circumstances. Or all our dissection or movements are away from the gliotic tumor bed and only on the tumor surface. And what all you have separated, you protect them with a cotton. Now we reach the midline of the face. Appearing there, the origin of the tumor is there from the fox now, and the tumor is gently being separated from the fox. And at this juncture, we must keep it in mind, we may have a high amount of vascularity from the fox where a tumor gets origin. We need to understand that and take a little time, coagulate all the feeders with the bipolar and separate the tumor from the fox as shown here and debulk the tumor. When it is going superiorly to the junction of the supracell sinus and the tumor, you need to be very slow and meticulous, not pulling the tumor down, because if it has invaded the inferior wall of the supracell sinus, we may cause tear in the sinus leading to torrential bleeding and problems. So gently, with a sharp dissection, you must do it and use the microscope to see the tumor extend superiorly. Sometimes if the microscope doesn't help, you use the endoscope. Now the whole tumor capsule is taken out from the deeper parts and from the midline. That is the nodular part of the tumor completely removed, and you can see the tumor separated from fox shown here. Now that is a normal gliotic brain, that's an empty tumor bed. Now at this juncture, if we have achieved hemostasis at every stage, you don't have to worry about bleeding at all. Now I want you to see the very well preserved cortical veins, and you can see the draining vein there and posterior vein. We have in between these two veins, protecting those veins. Most important is if you damage these veins, patient may develop extensive hemorrhagic infarct post-operatively and get into trouble, the hemiplegia, and sometimes mass effect, and sometimes lead to significant irreversible neurological deficits. We achieve the hemostasis and ask the anesthetist to increase the blood pressure by 30 to 40 millimeters compared to pre-op level, and wait for 10 minutes and confirm the hemostasis, and dura mater is closed. Now here, what happens due to the dissection? Get deficient because of the coagulation and the dissection. And many people use the dural substitutes, artificial dura and duragen, but we prefer to use pericranium from the bone flap. We harvest it, according to the requirement of the dural defect. And this is very simple, very easy, and very cheap, and easily available, and easily accepted by the body. So that is the dural, that's a dural graft, which is done. Dura is repaired and bone flap is replaced and scalp is closed. This is his post-operative clinical status on day 2, perfectly normal, no deficits, and absolutely fine. Day of discharge, on 5th day, he goes home. That is the case. This is a post-operative CT scan on day 2. The whole tumor is taken out. There is no swelling, there is no infarction, no hemorrhage. Tumor is taken out completely and no massive effect. So, special conditions we may get during the dissection and the removal of these lesions, that is dissection of the cortical veins, which is very important, which I mentioned to you just now. This is another tumor, parasagittal. You can see the cortical vein on the surface of the tumor, where it becomes very mandatory and important for us to do this way. In the retinoidal plane, we use 23 number needle as a knife and cut the arachnoid around the vein and all around, separate the tumor underlying the cortical vein and keep separating and protecting the vein and pull the tumor down from the cortical surface and take the tumor out. We must remember, for this type of tumors, the surgery can be made or broken by preservation of cortical veins. This is of utmost importance. Now, anteriorly, the vein is on the surface. Posteriorly, we follow the vein is inside the tumor. Again, one needs to be very important here. You have to dissect the tumor. You have to dissect the vein inside the tumor. That's very important, because now I want you to see, as you keep dissecting the tumor inside, the vein starts getting bulged and increased in size. It was obliterated because of the tumor. So we need to have patience and high illumination and high magnification dissection, and veins are always protected and separated as shown here and preserved. Then only we can achieve a good post-operative outcome with practically no deficits. Many a times, these patients come to us without neurological deficits. In spite of the tumor being large, they may come with seizures and we investigate. And post-operatively, patient going into hemiplegia or thrombosis, venous infarct is not acceptable. That is the preservation. You can see the posterior vein is preserved, the surface vein is preserved, anterior vein is preserved, and a tumor is taken out completely from keeping the vein, deeper vein, which the tumor was doing. And the bit of the tumor adherent to the vein, it is acceptable, but don't damage the vein. In some cases, inadvertently, if you damage the vein, put a small temporary clip on the vein, and end-to-end suturing is done with the 10-0 ethylone. That is always to be followed. Now you see completely the whole lesion is out and surface veins are very well preserved. Sometimes we get the fox getting infiltrated with the tumor, and we need to have Simpson's type 1 excision in these tumors. At that juncture, we need to cut the fox from the origin of the tumor, along with the origin of the tumor, and cut the fox and take off the tumor. This helps us in achieving type 1 Simpson's excision, and helps us to prevent the future recurrence of these lesions. Once you take off the tumor, now you see tumor is very densely adherent, and the fox has become thick at that juncture. About 1 inches to 1.5 inches of the fox below the superior sagittal sinus is cut, and the whole fox is taken out as shown here. You can see from this window where the fox we have removed parietal lobe. This is type 1 excision. Originally, the fox is excised along with the tumor, which helps recurrence of these lesions. This is the opposite frontal lobe, very well preserved, that's supracell sinus, and the fox is removed, the tumor is removed along with the fox attachment. This is an image of surgery. We anterior cerebral arteries, the distal anterior cerebral artery, which are very intimately connected with the inferior tumor, as shown here. Always, when you go deeper and deeper, we must keep a watch on both the anterior cerebral arteries. If you injure this anterior cerebral arteries, patient may have a very significant neurological deficits post-operatively. Sometimes it
Are you okay, Suresh? Sarath, are you there? Can you hear me?
I think his connection was lost, isn't it?
Yeah, I know we have a storm here in Miami. I don't know if it's me or not, but you can hear me, Sarath, right?
Yeah, we can hear you very well.
Okay, okay. I guess Suresh, have you got disconnected?
Connection was lost.
Yeah, I know we have a storm here in Miami. I don't know if it's me. Okay, we'll just wait. He'll come back.
Yeah, we can hear you.
Okay. Okay, until he comes back, welcome Jean-Pierre Kalala, Taha Al-Gahum, Havi Joshi, Dr. Milan Senjalilia, and Dr. Suresh. And who else? Tanvi Joshi. Welcome all. We're just waiting for Suresh to log back on. Okay, we're still waiting for Suresh. Can you contact him by phone, Sarath?
Yeah, let me try, John. Let me try.
Yeah,
give
because
me-
he doesn't seem to be coming back.
yeah, sure. One second.
Contact him by phone.
Yeah, let me try.
Yeah, he doesn't seem to be coming back.
Yeah, sure. One second.
Still waiting to hear.
John, his connection seems okay, and
Okay,
he will rejoin us in a few minutes' time, seems. So
okay.
just make him a panelist.
So you did talk to him, huh?
Yeah.
Okay. And he's actively trying to get back in.
John, his connection seems okay, and he will.
Surat, I'm getting that you have been invited as a panelist for Siddharth and Neurosurgical backgrounds.
Yeah, if anybody has any questions or comments while we're waiting, because Surash is coming back. He's just getting his stuff together, I guess. So if anybody has a question or comment for Surath, you're welcome to ask at this time. If not, we'll just wait. Yeah, if anybody has any questions or comments while we're waiting, because Surash is coming back. Just getting his stuff together, I guess. So if anybody has a question or comment for Surath, you're welcome to ask at this time. If not, we'll just wait.
John, it looks like that he's trying to reconnect with the link, but he cannot, get in with that link. Is
You
there
can't
anything we
get in
can
with
do
that
for-
link?
Yeah.
Okay, I'll give him that, give him this link.
Sure.
Let's see here.
John, it looks like that he's trying to reconnect with the link, but he cannot, get in with that link.
You can't get in with that link?
Yeah.
That's directly to the webcast. Give him that link. That's one, I have a hard time understanding. He got in the first time, but can't get in the second time. I don't know, that doesn't make sense to me. Unless he's not using a smartphone, he's at home.
John, is it possible for you to send me to WhatsApp the link, because I'm connected with the laptop.
Which link?
This link you just sent to me.
Yeah, that link is from the webcast directly. He should be able to get into it directly. Hold on.
Is it possible?
No, it's not.
The link if I'm connected with the laptop.
He'll get in, just keep trying. And how are you communicating with him?
Just through WhatsApp, yeah.
Through WhatsApp?
Yes, yes.
Oh, so I can communicate with them from WhatsApp. Okay, let me see here.
Sure.
Okay. Let's see. So, how are you communicating with him?
Just through WhatsApp, yeah.
Through WhatsApp? Okay, there's. Okay, put it in. Okay. this- Okay, no. Okay. Hmm. Suresh Dugan. Suresh Dugan. Did you get? I'm on your page. Okay, Suresh Dugani. Okay. I'm on your page. Okay, Suresh Dugani. Okay. Okay, I just WhatsApped them. I shall call them on WhatsApp. Okay, I just WhatsApped them. Okay, I tried calling him on WhatsApp. He didn't answer. And I'm trying, you're contacting him with WhatsApp, Sarath?
Yeah. I just contacted him through WhatsApp. Now he has got the link and he should be able to
Okay,
connect now.
okay. You're contacting him with WhatsApp, Sarath?
Yeah. I just contacted him through WhatsApp.
Yeah, I don't know. He doesn't seem to be communicating in WhatsApp either. Not a good sign.
Hmm.
We'll wait. Well, of course, we're gonna wait.
He's telling that his connection is really good. I don't know what happened.
Yeah, I doubt that because he's not communicating in WhatsApp. Not a good sign. Well, yeah, we'll be patient. This happens all the time to Dr. Goel.
Mhm.
I think he's got better service now, though. It hasn't.
Yeah.
It seems to be left. we'd have 80 people panel. Everyone hang around and wait.
I think he's back, is it?
There he is. Okay, very good. Okay, thanks for coming. Thanks for being persistent, Dr. Dugani. It's all yours. You're muted.
John, is it possible for you to unmute him?
No, he's got to do it.
Okay. Now, can you hear me?
Yes.
Yeah. Now we
Okay.
can hear you.
Now, see, another special situation we may have is when the tumor erodes the superior side sinus and the vertex and causes out of the skull as a large lesion invading the superior side sinus and invading the skull bone and getting into the scalp. And this is a venogram showing complete obliteration of superior parietal sinus in the midline, and the tumor is going down inside up to the corpus callosum, as I mentioned to you, and going up into the subgaleal space, including the scalp. So this lesion was operated. The midline incision. This is a lady with the permission. You can see the tumor coming out on the surface. Now the curvilinear flap is made and tumor is debulked as shown here and removed. The internal intracranial part and extracranial part of the tumor, which is coming out, is taken out. Tumor is quite firm. It needed scissors to cut. And on the right side, tumor is excised and debulked, and the surrounding dura mater is also excised. Now it is going down and infiltrating into the superior sagittal sinus, which is of great concern here. Now, good thing on MR venogram, the sinus was already blocked and obliterated, but we have to reach the anterior part of the sinus and the posterior part of the sinus so that you can excise completely inside the sinus so that it doesn't recur subsequently. This we did almost about 10 years back. The whole tumor is taken out along with the dural attachment posteriorly and laterally. That is the deeper part of the tumor which is removed. Now the medial part, which is onto the superior sagittal sinus, this is where the tumor is eroding into the superior sinus. We put the clamps on the sinus and block the sinus completely and take off the tumor along with the wall of the sinus and suture the wall of the sinus completely, because already the venogram had shown the near total obliteration of the sinus. So this is a suprasagittal excision and repair of the inferior sagittal sinus along with complete removal of the tumor. You can see here, this is the reconstruction of the scalp with the pericranial graft. This is excised completely, and that's a patient post-operatively. You can see no tumor is left, and she's surviving and doing very well, more than 10 years. When the tumor invades the superior sinus invasion, this is a gentleman presented with a large lesion. You can see the tumor in the frontal region invading the superior sagittal sinus, going across the midline and getting into the sinus. Again, this is of utmost importance to have our venogram to know what level the sinus is blocked. You can see the hyperostosis in the frontal region here, and lesion is quite extensive, infiltrating, invading the sinus. And this is the venogram showing the obliteration of the sinus and the posterior 1/3 of the anterior part of the sinus, and these are the cortical draining veins which are displaced. He was again underwent the frontal craniotomy And as we see here, I'll not waste time. We'll go only with the excision from the supracell sinus. This is a tumor from the fox, which originated and eroded the superior sagittal sinus and invaded the sinus. That is the part, anterior part. That's a fox, and that's a tumor which is debulked with the soft tissue debrider. We have reached the sinus fox junction. This is the sinus fox junction. We are now opening the superior sagittal sinus. Now I want you to see tumor inside the superior sagittal sinus, not coming out, and soft tissue debrider, how easily it cuts the tumor and sucks and helps us to take off the tumor. Now we are inside the superior sagittal sinus on the left side, and you can see the tumor in the sinus, and that is the posterior wall of the sinus. This is the posterior end of the sinus, where the sinus is open and starts bleeding. We have to take out the tumor till the sinus venous bleeding starts. Then only the sinus is open. That is a posterior limit. Now you can see the arachnoidal granulations inside the sinus. At the opposite side, since the veins opposite side are quite wet, but sinus is blocked, we can safely take off the tumor inside the sinus and take it out completely and cover the posterior end of the sinus with the Surgicel and a muscle piece, so that the post-operatively the sinus back bleeding will cause torrential bleeding and end fatally. This is the anterior part of the sinus part of the tumor, which is going on, and take as much anteriorly as possible, because anterior part of the sinus already there are collateral veins, which is the draining vein is already taken care of. They are draining through a different pathway, and you can safely go, we can sacrifice the sinus anteriorly. We are inside the superior sagittal sinus, and the tumor on the surface is taken out completely, as shown here. That is the anterior part of the superior sinus. We are taking out with a soft divider. This is the internal anatomy and structure of the superior sinus. We have reached most part of the tumor where it had invaded the sinus. Now here the venous bleeding will start because of the anterior patency, and we coagulate. We use the silver clips and clamp the sinus so that the obliteration, it is obliterated and the bleeding stops in these cases. Now at the end, complete tumor is taken out along with this intrasinus part, anterior to posterior, that is inside the sinus. You can see the arachnoidal granulations. Small bit of the tumor also is taken out to achieve Simpson's type 1 excision as shown here. This is a complete removal. Now again, we reconstruct sinus with the peritoneal graft. Take both the sinus walls in the dural closure and close the dura. This is the complete excision of the tumor along with the inside the suprasal sinus and the reconstruction of the sinus. Next, this is a postoperative scan, complete excision of the lesion and reconstruction. Patient is doing perfectly well. Now, anterior fox meningiomas, few cases, operated, pre-op and post-op through the bicoronal scalp incision. Another tumor eroding the skull anteriorly with hyperostosis pre-op and post-op. Large anterior fox meningioma pre-op and post-op. That is a mid-fox meningioma posteriorly going. You can see the plan of craniotomy and pre-op and post-op. Another one bifrontal, going both the sides and excised through semi-bicoronal flap. This is a mid-anterior frontal going posteriorly, involving the middle third of the sinus. Again, the midline craniotomy, a large flap and complete excision. Mid-fox meningiomas, a large meningioma that just now I showed you with the reconstruction of the superior sagittal sinus and excision from the sinus. Another one, a large mid-fox meningioma, completely removed with the middle curvilinear craniotomy as shown here. A large mid-fox meningioma, pre-op and post-op from the this is a bilateral frontal large meningioma. pre-op and post-op complete excision from both the sides. Flap. This bilateral frontal and parietal midline mass, pre-op and post-op, and this is the scalp flap, which was craniotomy, which was planned. This is another, just now you saw the same patient, what we excised. This is a large midline inferior fox meningioma. Craniotomy is semi-bicameral flap, and the frontal craniotomy, pre-operative and post-operative complete excision of the lesion. Posterior fox meningiomas, again occipital flap as shown, pre-op and post-op complete removal of these lesions. And another one, a large posterior fox meningioma, posterior occipital craniotomy, parieto-occipital, and removal completely. Another one, posterior fox torcular meningioma, pre-op and post-op lesion. And this is the posterior fox meningioma, complete excision. Complications we had: hemiparesis, hemiplegias, paraparesis, paraplegias, seizures, hemorrhagic infarcts, and meningitis. Believe me, all these deficits, if we are careful and if we manage them properly, can after 3 months or 2 months or 3 months, they recover completely and come back normally to us. Thank you very much for your patient hearing.
Okay, Surat.
Yeah, thank you very much. And it was an excellent presentation. And you could see, as always, big meningiomas, complicated cases, and complicated cases done so easily.
Thank you, Surat.
Thank
you very much.
And
thank you, Professor John.
So I want to ask you a few questions, and
Yes.
Because these parafalcine meningiomas, if you go to the literature is very sparse. It's not very commonly that we see a comprehensive, a comprehensive description regarding the falcine meningiomas. And regarding these dumbbell meningiomas, it's mainly, when we talk about this type of meningiomas, you have to think about the draining veins to the sinus, the management of the sinus, and how to get into the contralateral side through the falx. So these are the problems that we encounter, and these are the nuances that we need to know as neurosurgeons. So when you talk about these dumbbell-shaped tumors, which goes across the midline, so what is your approach? Do you usually do you always go through the falx, transfalcine approach, or you sometimes make another incision to the dura on the contralateral side and get into that through that space?
It's a very good question, Dr. Surat. It's a very important practical problem we face in bifrontal, either parietal frontal or parietal occipital meningioma. What we usually we prefer is we make a bicoronal flap, and the size of the tumor, the side of the tumor, which is maximum or the major bulk on that side, you do the craniotomy and start excising the lesion. And if the lesion is equal on both sides, then we do the craniotomy on the other side. If one side tumor is large and other side tumor is small, we make a cut in the fox and you can extract the tumor from the same approach, unilateral. But you keep a provision. You don't have to do the craniotomy. You keep the provision for craniotomy if necessary, but do unilateral sagittal craniotomy and excise the lesion completely.
Right. Thank you very much. And what is your tendency to take out the tumor which is inside the sinuses? Because nowadays, some surgeons, they prefer to do a subtotal resection and send the patient for radiotherapy. But me personally, as a neurosurgeon, I would like to take out as much as possible, keeping in mind always safe surgery and regarding the safety of the patient. So what is your tendency?
Again, that's a very important practical situation we face quite often. The venogram here is a very important guiding indication to us in these situations. If the sinus is already blocked and there is no flow, you go up to the posterior limit of the sinus, and you can excise it inside the sinus completely, as much if you can, as much as possible. And believe me, there will not be absolutely no bleeding at all. Number one, if the sinus is blocked because of invasion of the tumor, in these cases, always ipsilateral and contralateral, there is always collateral venous drainage which has already taken place. So you, by excising the sinus completely from front to back or intrasinus, as I showed here, is not going to create any trouble to you. If there is a difficulty, then as you rightly said, you can leave the part of the tumor inside the sinus and subject it for gamma knife. But by and large, better to excise it microsurgically. I agree with you. We can excise it completely.
Thank you very much. Thank you very much.
Thank you, Surat. Thank you.
John, if we have any questions from the...
Yeah, yes, there is a question from Agraj Misra. What is your opinion on posterior cranial fossa meningiomas, and how do you plan it?
Sorry, can you repeat the question again?
Okay, what
Sorry.
is your opinion on posterior cranial fossa meningiomas, and how do you plan it?
Yes, thank you, Dr. John. See, the posterior fossa meningiomas, they form a different locations, and here we have different types of meningiomas in the posterior fossa. We have cerebellar convexity, we have cerebral angle, we have retroclival, we have tentorial types of meningiomas in these locations. By and large, the convexity meningiomas can be excised completely by either midline or paramedian posterior suboccipital craniotomy. CP angle meningiomas, again, by retromastoid suboccipital craniotomy or pre-sigmoid craniotomy, depending on the infiltration and invasion, you can excise these lesions completely. Petroclival, again, they are formidable lesions where it all depends on the size, the growth pattern, and invasion into the brain stem and the petrous bone and the across and superiorly. There, if it is coming out well, you excise it. If it is not coming well and you think that going to be in trouble, you can leave behind the tumor, subject the patient for gamma knife. And meningiomas, again, you can excise it completely, and venogram showing the straight sinus block, you can safely excise these lesions completely through posterior supracerebellar infratentorial approach. You can take out these lesions completely. By and large, 70% to 80% of the posterior fossa meningiomas we can remove completely.
Okay, there's a question from Dr. Milan Sanjalia. He says, very informative presentation, sir. What is your opinion regarding use of pre-op endovascular treatment for vascular large meningiomas?
Yeah. Again, it's a very important, thank you, Dr. John. Again, it's a very important question. See, the preoperative embolization Many a times it helps in skull base meningiomas, basal meningiomas, like olfactory groove meningioma, sphenoid wing meningioma, or you can petroclival meningioma, where the feeding vessels are accessible, you can embolize them, number one. The convexity meningiomas, by and large, the embolization is quite difficult because they get blood supply from the distal meningeal vessels. So you can embolize superficial middle meningeal artery and do that. But we did do, in past, we did quite a many cases by doing this, but we felt by doing an embolization and subsequently taking for surgery, it didn't make much difference as far as the vascularity of the tumor is concerned. It was the same. Then what happened is, in few of the infiltrating or highly vascular hemangiopericytomas and meningiomas of the skull base, we, as a first same anesthesia, we clamped or ligated the external carotid artery. That made a lot of difference as compared to the embolization. It was much more beneficial, cheaper to the patient, and more result oriented. So I would prefer, suppose in many places in this our country or third world countries, we don't have the human resources and the technical skills to embolize these vessels. So in that situation, best is to go ahead cheaply and safely ligate or clamp the external carotid. By doing that, you are reducing the blood supply to the tumor almost by 80%. 80%. And same principle we follow when we are operating on glomus jugulares, where earlier days they used to embolize the ascending palatine or the maxillary artery or the branches of vertebral artery. They used to embolize, but it did not help. Again, the ligation of external carotid is of great help in these lesions. Thank you.
Yeah. Nice explanation. Yeah.
I think, excuse me, Suresh, I think our best student is here, Harshad Parekh. I think he has a few. Hello, Harshad, are you there?
Yes, John, I'm here.
Yeah, he's our best student. He comes to all the webcasts. Go ahead, Harshad.
Good evening, sir. Harshad Parekh, sir. Good evening.
Good evening, sir. Good evening.
Good evening, sir. Good evening. Nice to have you with us. It's great.
Always. I'm a great fan of yours.
I am too. Vice versa. Vice versa. Thank you very much, sir. Thank you.
Dr. Professor Suresh, both
Yes,
have very nice demonstration you have shown.
Thank
Excellent
you,
technique. Wonderful.
Thank you very much, sir.
I agree in your all principles of excision of meningioma.
Yes.
As I have learned greatly, meningioma is a surgery. Although people say it is straightforward and simple, but I feel one should not take it lightly. Second, it's a benign tumor. Third, meningioma is a surgery of preserving the veins. The most important part of a meningioma surgery is to preserve the vein.
Absolutely.
And safeguard the brain functions. So it is not imperative always to go for a Simpson grade 1. If you find in anterior 1/3, the sinus is involved, you can open the sinus and you can repair it. But in middle third or a posterior third of the sinus, one has to be very, very careful, because you never know where you will be able to, you will end up with the venous problems. So this is very, very, even Professor Al-Mefti has said many a times, if you feel that the tumor is not going to be, if you remove radically and patient is going to be having some problem post-op, don't attempt to leave it alone. Either you can observe it, and as you said, SRS is another option.
Very true, sir.
in my experience, preoperative embolization is not much of help, not much help. People have tried, and now almost everyone has recommended not to do it. And yes, we have done in past this clamping of external carotid artery or ligation also, and it works to some extent. So one has to be very careful regarding the approach, bilateral or unilateral. It is entirely an individual preference. Suppose what you have said very clear, nicely, if it is both the side is equally involved, then preferable to have a bilateral craniotomy rather than unilateral. But most of the time we can manage, as you rightly said, from the unilateral side. So the meningioma surgery is challenging, and it is very, very important that we must preserve the veins. If we don't know the venous anatomy, if we don't preserve the veins, spend your time as much as possible on preserving the veins. Dissect out the veins, separate it out from the capsule. Always be subarachnoid, always be subarachnoid. There is always an arachnoid space. Open the arachnoid below subarachnoid so that your veins will be separated out. And you can remove most of the time Simpson grade 1. Wonderfully shown, and your technique I've seen you many times doing. And so great job.
Thank you, sir. Absolutely. I 100% agree with you. 100%.
Thank you.
Your
Thank you.
principles are, as a senior professor, I mean, absolutely, I'm absolutely agree with you, sir. Your remarks are very well taken, sir.
Yeah.
That's it.
Thank you.
Thank you.
Thank
Very much. Thank you.
Rath, I don't see any more comments. Do you see anything?
No. Thank you very much, Dr. Harshad, for his expert opinion, as always. Wonderful.
Thank
to
you,
have
sir.
you.
He's a very senior professor.
Yes,
from
yes,
whom
I know.
we keep learning from him in
Yeah,
many of
yeah,
the
yeah.
our meetings and
It
conferences.
is vice versa.
It's an honor to have him with us. It's really an honor to have him with us.
It's a
No, no.
regular
It's
attendee
okay.
for the neurosurgical
Yes,
rounds, Sri Lankan rounds.
Yes,
Some-
yes.
Thank you. Thank you.
No, Sharath
Thank
is
you,
doing
Mr.
very well good work you are doing in Sri Lanka, and wonderful job despite of restricted facilities available, and you are doing all good cases, I must say.
True.
Thank you very much.
Thank you.
Thank you.
I agree with you, sir. Very
Let's
true.
all go visit Sarath in Sri Lanka. What do you
Yeah,
think,
yeah,
Sarath
sure.
and Suresh?
Thank you.
Looks like a beautiful place.
Yeah,
Okay.
Thank you. Thank you.
Okay, very good. Okay, until the next broadcast of Sri Lanka Neurosurgery Grand Rounds, Sarath will let us know. And thank you very much, Dr. Tsugani, for another great presentation. And Harshad, thank you very much for contributing to the webcast, and we'll see you shortly.
Thank you, John. Thank you.
Thank you very much.
You could stay there.
Bye.
I'm just